my name is Amy. I'm a sickle cell patient, and with me I have my Dr.
Dina Oevermann. Thanks for the introduction, Amy. I'm a senior physician here at Charité at the Pediatric Hematology Oncology Department, and I am head of the hemoglobinopathy program treating only children with sickle cell disease in Tennessee.
Thank you, and nice having you on, Dr. Oevermann. Screening for sickle cell disease has been happening since March 30th, 2021, as described by the Federal Joint Committee. How has that come about? How did it come about?
That's a really good question. My colleague who was here before me and was head of the program before me, he noticed that the numbers of sickle cell patients were increasing over the last 15 years. Due to migration and due to all these movements, he saw that his outpatient clinic tripled within a short period. So he thought we have to be ahead and we have to find out before the complications occur. And newborn screening is done on the third day of life of a baby, and you do it because you want to diagnose everybody who needs immediate treatment or who needs immediate and early knowledge about the disease, like hypothyroidism, things like that. And so he found, together with some laboratory people, he found a method that was really cheap, and he introduced it. They had different pilot trials over around 8 years, and he could show first that it was worth it because we had a lot of sickle cell births in Germany, and second, that it was cheap and it was it was doable. And then in 2021, like you said, the GBA approved the newborn screening for sickle cell disease, and since then we have been doing it, and I can tell you that we have around 140 newborn babies every year in Germany with sickle cell disease, which is a pretty high number. And the advantage of newborn screening, of course, is that you can diagnose a patient before any complication has even occurred. And we can teach parents and patients about the disease. We can tell them what they have to expect, what to watch out for, to go to see a doctor when the child has fever, to give penicillin and initiate the treatment and the diagnostics early on. So this has been a great development for us.
Screening is a great development. You've mentioned your colleague before you. Since when have you been working with sickle cell patients, and currently how many patients do you have here in the outbreak?
So I'm doing this, I've been doing this for 8 years now, so since 2017. And when I started, I had around 150 patients, sickle cell and thalassemia patients, and now I have around 270. So the numbers are still increasing, and it's just important that we do this and that we gain visibility.
Yes, that's very important, like you said, for the disease to be known and be properly handled.
Yes.
Where does sickle cell occur, sickle cell disease? Like, where does it predominantly occur?
Yeah. So in Germany, as you noticed, it's a rare disease. It still accounts as a rare disease. But in areas like Sub-Saharan Africa, like India and Brazil, and also Syria and Lebanon, it is globally one of the most common inherited diseases. So it occurs where malaria is. And why is that? It's like that because carriers of sickle cell disease, so the ones who are not severely sick but carrier, they are A and S, and they are healthy but carry the disease inside, they have milder malaria, so they do not get so sick. And that is why in the past they survived malaria, and that is why sickle cell disease spread where malaria occurred. So kind of, I don't know. I'm not sure if nature did a good job here.
Doesn't seem like it.
No.
You also work and research in the field of pediatrics, stem cell transplantation, and hemoglobinopathy. Can you explain to us what exactly you do there?
Yes, of course. So pediatric stem cell transplantation is different from adults because in adults you mainly transplant patients with malignant disease like leukemia and lymphoma, and they have to be treated immediately. And in pediatrics you also have children with immune deficiencies or patients with hemoglobinopathies like sickle cell disease and thalassemia. And here the the outcomes and the emphasis where you put your spotlight on is they are different because you try to avoid certain complications really by far. You want to try to avoid graft-versus-host disease, and you want to try to avoid graft rejection. Difficult words. GVHD is when the donor cells attack the recipient body, so attack the patient, and that leads to really severe complications. And I'm trying to find predictors to avoid these complications. You know, I try to find predictors that can tell you when GVHD occurs and when it won't. And I try to find better matching between donor and patient. I try to find better paths to avoid these complications totally. In general, preparation is everything in stem cell transplantation. So I try to do better preparation strategies and better strategies to avoid graft rejection so that the patient does not reject the graft. In a second step, you know that gene therapy is coming up now, and we are allowed to start. So gene therapy means that you can repair the patient cells. You do not need a donor anymore, which is a huge advantage because not everybody has a donor, you know. And but we do not know what happens to the donor or the patient cells after having been transplanted, you know. So we do not know if the patient cells remain healthy because they will receive busulfan, they will receive chemotherapy, and we have to make sure that nothing bad comes out of that. So we really try to find out if there is what is the hematopoiesis doing, so like the blood production doing after gene therapy and after stem cell transplant. And my third line of research is global health. So I have a close cooperation with Kenya, with Nairobi, with my colleague Maria from Ruaraka Nema in Nairobi, and together we having a project to improve treatment of sickle cell patients in Nairobi, Kenya. And my aim and our aim is to improve treatment and to bring the therapies to where the patients are. So that's my ultimate goal.
That's amazing. And so would you say that the gene therapy, like from the person itself, from the patient, have less risk of rejection than stem cell?
We don't know yet because it's really early to tell. It's too early to tell. The results so far, which means that after 5 to 7 years after therapy, it looks good. But I cannot tell you what happens after 20 years because it hasn't been done for 20 years. For stem cell transplant, I know the numbers, you know. So this is something we'll have to find out.
And I hope sickle cell patients like myself get to have more options in the coming future, and therapies that don't have like effects or risk afterwards, or a future like that.
I mean that's exactly what you're saying. That should be the goal. Find a non-toxic cure for a non-malignant or benign disease. Yes, you're right.
And what advice would you give to people with sickle cell like myself, or sickle cell AS like carriers and families about sickle cell and the difficulties or sickle cell in general?
Do not hide. Yeah.
Good one, yeah,
Yeah.
it's true.
Do not hide. Come, get out here. Show yourself. Talk about it. Find each other and work together. And because if you work together, we can work against the disease. And I can show you, and we can show you that it's treatable, that it's that you can live a good life with the disease. That if you can share all your concerns, they might get smaller. And I think this is something everybody needs to learn, and to take away the stigma from the disease, because it's not anybody's fault.
No, not true. That is true. It was really nice having you, and thank you for your time. I hope you have a nice rest of your evening. Thank you, Dr. Oevermann. Thank you, viewers, for watching. Bye.